Good evening, everyone, and welcome back to our Dubai Shoulder webinars. This is today. It's a very interesting webinar on very important subject in shoulder surgery, which is the instability. And we will talk today specifically in the massive bone loss and the procedures which we can address the instability in cases of massive bone loss. As you know, the option of treatment, which is mainly the Latarjet. We have two eminent speakers today to talk about Latarjet, and it's gonna be fun to do like a crossfire between the open Latarjet with Alex Lädermann and the arthroscopic one with Shariff Bishai. Then we'll move on to other option of treatment, especially in the failed Latarjet and even in primary as well. With Ziyad El Qirem, he will show us how he is doing arthroscopic iliac crest graft. And then we will end our webinar with a very interesting topic, very interesting presentation with Dr. Ivan Wong, who is the president of the Arthroscopy Association of Canada. He will share with us tonight his experience with the arthroscopic iliac crest, arthroscopic distal tibial allograft. So I would like to welcome our four speakers, and I hope it's gonna be interesting webinar tonight. So we'll start with our first speaker, Dr. Shariff Bishai, who is a professor of orthopedic surgery, and he's practicing in Detroit in USA. Shariff is a well-known sports injury surgeon in US, and he will show us tonight how he's doing arthroscopic Latarjet. Please, Shariff.
Thank you so much, and honored to be on tonight with this esteemed panel. All right. So today my charge is to discuss bone block procedures for recurrent instability, especially with bone loss. And the goal here is to figure out what's the right thing to do for the patient. Here are my disclosures. So when you look back at this editorial a few years ago, and it's really interesting when you look at it, when I break it down, it's a good friend, Paul Favorito, that was doing a surgery, and his senior partner told him, wow, you're wasting your time doing this procedure arthroscopically. And this was the year 2000. And this was an arthroscopic rotator cuff. And the question is whether we will hold this true for arthroscopic Latarjet. So far, it seems that everything we do open eventually goes towards the scope. Let's first understand what we're talking about. So we're talking about on-track, off-track lesions. And so if we have an on-track lesion where it is non-engaging and the Hill-Sachs lesion is smaller than the glenoid tract, we're not talking about these procedures for a bone block procedure. But if we do, however, have a Hill-Sachs that is larger than the glenoid tract, we're talking about this engaging off-track lesion that needs something more than a soft tissue procedure. To simplify this, we're just looking at these pictures here, and you can see in the top left the on-track versus the off-track, and then we're going to have to measure this deficiency in order to better understand how much bone we need and how much other support we need in the shoulder. And so in Michigan and in the US, we have very poor roads. So we want to make sure that our tire is wider than the pothole, or else we'll have something bad like this happen if we try to do the wrong procedure. So when we look at this, we have to measure from the bare spot centrally into the front and back should be about equal. So how can we do that? So starting in the clinic, one of the things we learned from Dr. Gerber is that if we take our x-ray and on the AP, we see a loss of this anterior sclerotic line, we can feel with 100% specificity that there's probably some loss of anterior inferior bone. A Bourneau view is also very helpful, and I think this is paramount in treating these patients. So if we don't have this as part of your armamentarium, you should. So when we look at these dislocators, that first-time dislocator can have upwards of 7% bone loss. But with that recurrent dislocations, 23% of these patients have bone loss. So it's very important to fix these patients early. An article that's in press right now by Hedrick, 895 patients looking at the predictors of glenoid bone loss, was older age, male sex, non-white, and contact sports. But also for the posterior humeral bone loss, which is the Hill-Sachs, it's very similar. The key here is, as many of the rest of the world uses as well, the instability severity index score. I think this is going to be helpful to guide us to making the right decision. So when Blanc looked at it back in 2006, he said that somewhere around 25% bone loss or more is probably what we need to worry about. And this is what it ends up looking like, and tends to be why we're here for doing a bone block procedure. But over the years, this has changed. And so when we look at some of the later findings, this critical value, this particular article showed 17.3%. When Tainley and his group looked at it, it was 15%. When JT Tokish and his group looked at it, it was 13.5%. So somewhere around 10% and above is where we're going to start seeing this quote unquote critical bone loss. But under 10% tends to, we can all agree, is the non-critical bone loss. So what we have to do is be prepared to go to surgery and have different options planned. Many cases, essentially, if you get a CT and whatnot, you know what you're getting into, but sometimes you might want to wait and be prepared for a Bankart versus a Latarjet or some sort of bone block procedure. And why this is important is when you start doing this external rotation, you can see we're missing anterior bone loss, and then we externally rotate this arm. You can see that we have a significant amount of posterior bone loss as well, with a wide but shallow Hill-Sachs, which is actually a little bit more important than the shallow deep, or excuse me, I should say the narrow deep, because this will engage. And so this patient needs some type of bone block procedure. So can we preoperatively plan these procedures? And the answer is yes. Hardy looked at this and looked at these different ways to understand the CTs. And he said, I can measure the width of my glenoid as well as the coracoid and add these two together, and coming up with about 20% for our alpha angle for our screws. And that would give us the length of our screws. And why that's important is we want to make sure that we're not too long, especially with the more superior screw, as we can, if we go too long, we can by that suprascapular nerve posteriorly, and we don't want to do that and injure the suprascapular nerve and injure the infraspinatus at the spinal glenoid notch. So again, we also need to understand the morphology of the coracoid. And so looking at this also by Hardy, he came up with a very similar type of understanding with the flat, the curved, and the banana shape, much like an acromion, as Bigliani taught us years ago. And this, again, will help us understand what's the right way to facilitate a particular type of graft to our glenoid. And if we can accommodate for this and be prepared for this, then we can have a flush fit, so we can have a good fit to the anterior glenoid and a good fixation as well. What we also need to understand about the coracoid is, at least for the system I use, and I believe I do the same, we need about 23 millimeters of coracoid, or at least, or in his case, distal tibia, in order to make sure that we have enough bone for screw fixation. And this is important. So whatever system you use, you need to know how much bone you need as to make sure that you're appropriately accommodating, so that we don't split our graft or we don't have a loss of fixation, as this is leading to different problems with the post-operative care of the patient. So again, looking at graft positioning with the CT scans, especially with arthroscopic Latarjet, one of the benefits is that our position is better. We can see it a little bit more clearly because we're seeing it in different views. We can look from different angles, and we can see in his study there was no lateral positioning noted. And this is important in that alpha angles are right around 19.9%, called 20%. We want to make sure that if it's over 25%, we're going to get in trouble, as we're pointing right at the spinal glenoid notch. So not only are our position of our screws better, but we also have better positioning of the graft. Hardy also showed us that 58 patients looking 22 mini open versus 36 arthroscopic. In the arthroscopic Latarjet group, there's significantly less pain during that first postoperative week, and there's better positioning along the equator of that the coracoid on that glenoid when done arthroscopically. The outcomes were comparable, but overall better with the pain loss or pain restriction and the position. So does the sling effect make a difference? And George Athwell's group looked at this, and they said that the Latarjet procedures does aid in the stability of shoulders with moderate anterior bone loss, and the effect is augmented by that conjoint tendon with the dynamic sling effect. So again, when we look at that sling effect, and when we looked at this, 90% or 90 degrees and 0 versus 90-90 showed that the main stabilizing mechanism of a Latarjet was that sling effect. So if we're only doing just a bone block, are we able to give as much stability as we need for the shoulder to prevent recurrence of instability. Ivan will show you this later, and he's come up with an outstanding way to fix with the anterior bone loss. And so you can compare the two with the Latarjet here on the left and the glenoid anatomic reconstruction on the right. I'll let him get into that as well. And this is one of his slides as well. And one of the really amazing things about this is it's a very unique procedure that's very simple to do, comparatively speaking, especially there's no subscap split. He'll get into all the nuances and the good parts of that. One thing, however, is resorption, whether it be distal tibia, and Ivan's shown that as well, and even Preventra has shown that. And so we worry about, we need to load this bone. And unfortunately, when we do it this way, we actually make the graft extra articular. And what worries me is, although 86% have some resorption, what that means is 72.7% had at least 25% resorption. So that's a pretty big number. But I still think this is an important way to fix it, as you need to have more than one ability to fix bone loss. So in this particular case, I won't say that I never do it. I do use this. This is a great way to fix a shoulder. But for me, I still like to go first line of defense is the arthroscopic Latarjet because of the sling effect. And again, here we can, comparatively speaking, the AAGR does have a slightly higher resorption rate, but there is no statistical significance between the two procedures with the graft surface, the size of grafts, or the AP dimensions of the reconstructed glenoid. So they are in some case synonymous, but I would hate to debate, Ivan, because I think they are used for different reasons. So again, when we look at complications, because that's one place everyone will say, well, the Latarjet is a difficult procedure, and then arthroscopic is much more difficult. But we can see that even with open Latarjet, 9% 90-day complication rate, graft or hardware failure in about 5%, nerve injuries in about 3%. Where their biggest problem is you really need to preoperatively plan and position that graft accordingly. That's why I think the arthroscopic Latarjet allows me to see it better at the time of surgery, as I'm looking right at the glenoid in multiple views. And the suprascapular nerve is it's really important that we know where those screws are heading. We know the angle, because we don't want to be more than 25% on that alpha angle as we insert our screws. When comparing arthroscopic versus open complications, Matt Ravenscroft showed us that in his first 120, he had no infections, he had no transient nerve injury, 0.8% transient nerve injury, no permanent nerve injuries, and no redislocation rate compared to the J.P. Warner's work that was published before. So when doing an arthroscopic Latarjet, you can see here, I'll speed it up just for time's sake. You can see our bone loss here. Not a significant amount on the grand scale. I mean, this is one that she did very well, and I think this is was a good one for her, as she did have some bone loss and did have a seizure disorder, so I think she needed a little bit more than just a soft tissue procedure. So here we are looking for the axillary nerve. And so we're under the coracoid, viewing from the D portal, and we're coming through. And then there you can see the axillary nerve in just 1 second. There it is. So now I know where to work. So now I'm in front of that conjoint tendon, clearing off the soft tissue in the subpec area. And we're going to release all the way down this conjoint tendon until we see inferiorly. Again, we're doing that until we are able to now set up our J port. So this is the top of the coracoid. We're going to take this all the way back to the CC ligaments, but not through. So we're going to come through the subscap where we feel we're going to make our subscap split, go lateral to this in order to make our M portal. The M portal is very similar to what Ivan has popularized as the Halifax portal as well, but I know his is just a little bit more superior to give him a great line of sight to that anterior glenoid. So once we bring that out, I can make my M portal from the inside to the outside, and therefore I know that I'm not injuring anything. So now we're on top of the coracoid to elevate all this soft tissue, and we're going to, again, take that back to the CC ligaments. So now we can take the pec minor off, and we're going to take it directly off that medial coracoid. And as I pull back, you'll see the difference of the conjoint tendon versus the obliquity of the pec minor tendon. And once we get circumferentially around, we can come through, and now I'm where I want my subscap split to be, and I can start my subscap split. Conjoint tendon is on the right side. You can see biceps tendon over on the left. So now we don't want to get into the biceps. And now I know exactly where I need to be for my subscap split. And we're going to go through and do that. So now I'm also going to decorticate some of the inferior portion of the coracoid, as I want to have a nice bleeding bone bed, and make sure, because I know the shape, where I need to take more bone to lay flat on that coracoid, or on the glenoid, excuse me. So here we are with our guide. I want about 7 millimeters from the anterior tip so that I don't fracture it as I put it in. So once we do that, and this is why we need at least 23 millimeters, we got to make sure we have enough bone to accommodate the 2 screws. So now we're going to drill our 2 pilot holes. And this is in the coracoid. So while the coracoid's still attached, all the preparation is happening. And then we'll drill the second hole. And the full video of this was it's about a 53-minute case, and this particular one is on my YouTube channel if you'd like to watch the whole procedure. But now you can take this all the way back, and now it's decorticated. Now we're going to start making our stress riser here, circumferentially around that coracoid. I'm going to fast forward just a little bit. So now, once that coracoid is cut, we can see it sitting there waiting for us. We're going to use our guide to grab it, and once we grab it, we're going to cut some of that excess bone so that it sits flush. And so we're just going to burr that tissue. And then once the subscap split is open, we can elevate it with 2 switching sticks. And I will say that Ivan does have an advantage here because he does not have to have a split. And then we'll come through, twist our hand, and there's that conjoint coming in with the coracoid. During this time, the arm's in slight internal rotation and somebody pulling it posterior to get it out of the way. And then we want to line it up here with the subchondral bone. We don't want to be flush here. We want to be about 4 millimeters inset, as oftentimes if you ever have to come back and look, it does get covered with fibrous tissue. So we want to make sure we don't have any lateral positioning here. So we're going to do our drill, followed by our screw. And we'll put that second screw in. So there we have it. With the arthroscopic Latarjet, there is no closure of the capsule. There is no reconstruction utilizing a portion of the CA ligament like we do with the open procedure. And again, if I have a high contact athlete, like in this professional hockey player, we did a CT scan to confirm the positioning and make sure that it was healed before we released them to play. And again, just no matter what you're doing, always worry about that humerus. And if it's a larger lesion, you may need some type of procedure, just like in this particular case where he did obviously need an arthroscopic Latarjet, but also had a large posterior injury that was engaging that needed to be addressed. And so in this particular case, we were able to address this at the same time of the procedure. So the arthroscopic Latarjet was completed, and through a small posterior approach, we were able to also take care of the posterior aspect of the humeral head. So in summary, you got to have it, no matter what system or decision you make of how to fix this, you need a good workup. You need to understand that there is bone loss. From the standpoint of arthroscopic Latarjet, there's decreased narcotic use, less postoperative pain, better visualization, less soft tissue trauma, less retraction of the neurovascular structures, better graft positioning. Cosmetically, it's appealing. You also have the sling effect compared to some of the other ways. And then also, no matter what you do, address that humeral bone loss. Thank you.
Thank you so much, Shariff, for this very nice presentation as usual. I will move on with Alexandre Lädermann, who is the well-known shoulder surgeon from Switzerland. And Dr. Lädermann will tell us why he doesn't like arthroscopic Latarjet, or why he stopped doing arthroscopic Latarjet and he preferred the open Latarjet.
Usama, thank you very much for this nice introduction and for the invitation. So this is my disclosure. I don't have any disclosure related to this presentation. You will find more information on the arthroscopic website if you want, and as well on the teaching and participative website, bmed.com, on the wiki part. So as it has been said, I'm coming from Switzerland. As Maurice Montmuller, you maybe know this surgeon. He has been very active in the field of the hip. He developed a stem. He has been elected shoulder of the last century, best shoulder of the last century. And actually, he's one of the founder of AO. And you all know AO with these crucial concept like the ORIF, open reduction internal fixation, something that you can typically obtain with a Philos plate. But the concept evolved and some surgeons tried to make it simpler. So there is the OIF called open internal fixation. This is something that you can typically obtain with pinning. There is also the ODIF, the open displacement internal fixation obtained with a nail. And finally, with the scope, the AID, that is the arthroscopic internal decoration, something that you can typically obtain with an arthroscopic Latarjet. So why shall we always reinvent the wheel, knowing that the Latarjet is unique because it has never failed since 77 years, and this is quite unique in the field of shoulder surgery. And why does it remain a challenge even for the best one? You know Pascal Boileau, you know Laurent Lafosse. Some of them admitted that arthroscopic Latarjet is not so easy. So in 2011, when I get my own practice, I was working in the same city than Laurent Lafosse. I said to myself, okay, if I don't do arthroscopic Latarjet, Laurent will do them for me. So I began. And in 2014, I was the first one to have the honesty to look back at my results. It has been published in the Crest 2016. And I had more complication, more screw placement, inaccuracy, persistent apprehension, and recurrences with the arthroscopic technique. So one of the conclusions of this article was that maybe I'm completely miserable with the scope and I should stop. And I stopped arthroscopic Latarjet. But what about the other ones? And if you look at all, I will say the valuable study. So the symposium of the French Arthroscopic Society, this time done with very good surgeons, Valch, Lafosse, Boileau, Netton, Bart, and so on. The very nice study of Zhu, the study that has just been published by Nicolas Bonnevial, probably one of the best fellows from Pascal Boileau. They have exactly the same result that mine. Clinically, it seems comparable, but radiologically, it's not so good, except for the graft positioning with the Boileau technique, knowing that open surgeon did not use a guide that were already available on the market. And in conclusion of all this study, it's absolutely clear that it takes more time to obtain bone fusion. You have smaller graft, this is more expensive, and this is time consuming. So just to show you and to give you some, crucial information about all these complications. This graph show you the placement inaccuracy that you can have with an arthroscopic Latarjet. And the graft is not at the wrong place in 5% of the case. It's not in 10% of the case, not in 20. This is in more than 50% of the case, not at the perfect place, more than 50% of the case. Another problem is the screw that is not parallel to the glenoid. And this is a crucial point. You see that if your screw is not parallel, when you see the graft from the joint, it looks absolutely perfect. But divergence of the screw actually creates a non-contact of the graft with the anterior glenoid, and it's very difficult to have parallel screw with an arthroscopic Latarjet. Very difficult, and this explains why they have such a high rate on non-union or delayed union. And this is not minimally invasive. I mean, this is a very invasive non-anatomic procedure with 5 to 7 skin incisions with the arthroscopic technique that are longer than the 4 to 5 centimeter that I do for the open one. You go 5 times through the deltoid, you go 1 time through the posterior cuff, 1 through the pec major versus a complete anatomic with the open technique. What about the cosmetic appearance? This might be a criteria. This lady said to me in OR, I forgot to say to you, sir, that I don't want any skin incision. So you just do a skin incision in the axillary fold, and this is not anymore a problem. This is a post-operative picture. And you don't do the same jump. The graft is smaller. You do not prepare as well the inferior decortication, and this also explains the low rate of fusion. There is at least 20% of non-union. This is huge. It had just published in the AGSM. What about the subscapular split? It's usually too high, and this explains why it's more difficult to recover external rotation. It's also because it's difficult to do the split in the muscle, because also, of course, there is the axillary nerve that is right in front of you with the scope. What about the split? When I do a split during an open Latarjet, I put my arm in abduction and elevation, maximal external rotation, and this is how you can reach the lower third of the subscap. What about the scope? Is clearly more difficult, and usually when you do it with the scope, you are in the upper third, and this also limits external rotation. You should be actually at the level of the green line. And I love to reconstruct the capsule and the labrum. If you put everything on the glenoid, so if you reconstruct the capsule and the labrum between the glenoid and the graft, you will limit external rotation. So it's crucial to reinsertion of the labrum between the glenoid and the graft, and to reinsert the capsule on the graft. So this has been clearly demonstrated in the past. Does the program stop after the learning curve? Absolutely not. Laurent Lafosse had the honesty to present some very difficult situation. And what will happen if it has not been a giant like Laurent? This would have been a disaster. What will have happened if a poor surgeon like me would have had such complication? What about the cost? The much higher direct cost of the arthroscopic does not seem at present to be justified by a benefit to the patient. I did not say this. This has been published by Rondelli. And it's more time consuming. When you begin an open Latarjet at 5 p.m., you know that at 5:25 you are finished. At 5:30 you are in your car so you can see your child. When you begin an arthroscopic Latarjet at 5, you never know, never, when it's going to be finished, never. So this is a small video. So this is the technique that I use. I'm not sure that we will have enough time. This is a 5-minute video, it should be okay. So anatomic dissection. So you just retract the pectoralis medially, the deltoid laterally and superiorly. Then you put a Hohmann retractor on the cricoid process. This is something that is really easy. Then you put your arm in abduction external rotation. This will expose nicely the lateral border of the conjunct tendon that you can release, and you release as well the CA ligament that you cut at least 1.5 centimeters from the cricoid process. When this is done, you just release the pec minor from the cricoid process. Still in adduction, you introduce 90 degrees saw, and you need to have at least 2.5 centimeters of graft. Two is really the minimum. I love to have 2.5 to 3 centimeters, and you need to see the knee of the cricoid process. Then you do a nice decortication of the inferior graft. You see that with the open technique, this is something that is really easy. Remove this spikes with a ronger, do a nice decortication still with the 90 degrees blade, and then you will do your 2 holes with something that, so this graft is 2.5 usually. For me, it's really minimum. 3.2 holes, because I use 4.5, exactly like Gilles Valch was doing. Honestly, this, you need to have large screw if you want to have good compression, good bone healing, and so on. You had the cricoid process under the pec major. You just split this space, and what I showed you previously, you put your arm in abduction, maximal external rotation. This will nicely expose the inferior part of the subscapularis. When this is done, you push a Hohmann between the subscap and the capsule, and that's it. You will never have a look to the axillary nerve, you don't care. I never had a neurological lesion after a Latarjet, just because you don't care. You just retract gently the structure, and this is enough. And then when you expose the capsule, put a posterior, you do a posterior push, and you will see exactly where is the joint line. So now with a knife, you will do your vertical capsulotomy. You go from the inferior to superior, at least 1.5 centimeter to protect the axillary nerve. This is a key instrument for this procedure. This is a TRIA retractor. It has been developed by Michel Tria. You introduce this retractor in internal rotation, and then when it's done, you just retract the human head laterally. This will nicely expose the anterior glenoid. I put 2-stage suture on the labrum because I will reattach the labrum later on. I put this small Hohmann retractor inferiorly, and then this broad glenoid retractor, also called link retractor, medially. This retractor is the key because it will allow you to push firmly medially and to expose nicely the anterior glenoid. You see, no nerve, easy. You just put your first wire at 8 millimeters from the glenoid. It has to go in a superior direction, and it has to be parallel to the glenoid. First screw is always in my hand, 28 millimeters. This is clearly enough, and usually you will never be in the suprascapular nerve, particularly if you are parallel. And then you put the superior screw, and have a look now. You do a complete reconstruction, meaning that when I will pull on my suture, and this is in press in arthroscopic technique, you just do a nice reinsertion of the labrum between the glenoid and the capsule. And when this is done, I will reattach my capsule on my CA ligament. And I think that this capsular reconstruction is very important. We show in 2016 that we have some residual persistent micromotion that I will show you we try now to avoid. So I pass my suture through the CA ligament, and then my assistant will push the human head posteriorly. I will put my arm in elevation, external rotation to avoid external rotation limitation postoperatively. So elevation, adduction, external rotation, and then one of the assistants will do posterior level push. And this will completely reduce the human head, because if you have a look on the web, everybody is reconstructing the capsule with the human head anteriorly dislocated. So you need to reduce the human head before tightening your capsule. Just one suture on the lateral subscapularis, and you will see at the end 4.5 centimeters. This is what I do usually. And as you can see, the screw are parallel, graft at the right place. So this is my way, no more sling. So this is an old video. Today I'm just finishing a study sling versus nothing. My patient doesn't need any more sling. They don't have more pseudarthrosis. So this is at 5 days. And you see that this patient has already almost complete range of motion. Interestingly, the Latarjet does not limit postoperative range of motion. It's even better than preoperatively because the patient are confident. My postoperative rehabilitation, first weeks, they just walk and do home trainer, no other sports. At 6 weeks, they do all sports except overhead sports, contact sports, and crazy sports like base jump. And after 3 months, they are free. They can absolutely do everything. So shall I go back to arthroscopic? I'm sorry, but today there is no advantage with the scope. It's longer. This is more expensive, more dangerous. And I think that we should stop to talk about the study of GP Warner. This study, we don't have this kind of complication if you do properly the Latarjet. You will have more pseudarthrosis with the scope, longer healing, bad graft positioning, smaller graft, and you don't do an efficient anterior capsular reconstruction with the human head reduction. I just invite you to the next Valiser shoulder course if you want to know more about these nice techniques. It's going to be in April 2002, and there will be a multiplex from Dubai if you don't like snow. Thank you very much for your attention.
Thank you so much, Alex, for this very nice presentation. And thank you for convincing us that those guys like me who is still doing open Latarjet is on the right track. I'll move on to our third speaker, my friend Ziyad El Qirem from Jordan. He will show us today another technique he's doing, which is arthroscopic iliac crest graft. Ziyad.
You're still muted.
Yeah, thank you, Usama, for this kind of invitation. My name is Ziyad. I'm from Jordan. I will talk about the arthroscopic iliac crest. So this is my disclosure here. So arthroscopic autologous iliac crest has been described in 2014 by German groups. And this is used iliac crest with fixation with 2 screws. And in this techniques, they mentioned that they go through transtendinous subscapularis. So they have another portal which go through the subscapularis. And when you go to the systematic review for the arthroscopic iliac crest, you can see that there is no long-term follow-up for arthroscopic iliac crest. So at least within 4 years, you have a very good or excellent results, but we don't know that in a long term, like 20 years, we don't have a long-term follow-up for arthroscopic iliac crest. So the technique which I will talk about today, it's published in Arthroscopic Technique in 2019 in one of the Germany groups. They mentioned that it's a non-metal fixation for the graft. And the beauty of this, that there's no need for subscapular splitting. There is no metals. And still you don't need the allograft. So actually it's autologous allografts in our countries or in the Middle East areas. Not always you have allografts. So this is still a feasible option for bone procedures. The second thing is that still you can do these type of procedure if you have a very bad anterior complex. So if you have a chronic patients and they don't have a good bone loss, like 5–10% bone loss, but still they have a very bad anterior tissue. Still, I'll do iliac crest bone graft, especially if he has a high sports activity. So I will go with a more robust fixation. So very quick animation. So usually after cleaning the whole anterior area, so I use this a hook guide with a anterior reference. So usually it's almost like 8 millimeters from the glenoid surface with a 2 drill cannulated drill bits. Then you drill these 2 cannulated drill, one inferior, one superior, in the inferior pole of the glenoid, and you retrieve the wire all the way through the rotator interval. Then you try to retrieve the fiber tape. And you have a fiber tape, you have a tiger tape, then you're gonna retrieve this all the way from posterior, all the way to anterior through the interval. Then you need to pass these fiber tape from inside the graft all the way to make a loop and go from outside to inside the graft. Then you need to retrieve these tape all the way to the posterior. Then we have 2 limbs in the posterior edge. We have fiber tape and tiger tape, so we're gonna hold each other. Then we have 2 knots, exactly like what we have in a tightrope. Then you need to push the knots all the way in the posterior part. Then we start to use a tensioner. So this is the tensioner. We're going to use this like 4 or 5 times to make sure that we have a proper tension between the graft and the anterior part of the glenoid. Then you cut the sutures, and this is what we have in the final construct. So usually I do this in lateral decubitus. At the same time, I mark the side of the iliac crest harvesting. You can use wherever traction for the lateral decubitus. Then I start to do a tricortical graft harvesting. So you can see this is a tricortical graft, and the size of the graft, usually the length between 2.5 to 3 centimeter, and the depth of the graft between 1.5 up to 2 centimeters. So this will increase the width of the glenoid up to 2 centimeters. So is this after that, do you need the sling effect? I'm not sure. Then after that, you prepare the graft with 2 holes, 1 proximal hole, 1 distal hole, with a small drill bit, 2.3 up to 3 millimeter drill bit. Then after that, This is a small video to show how exactly the technique. This is a left shoulder, and I'm viewing from the anterior superior portal. So I start to clean up all the way the capsulolabral tissue. Then I need to prepare the medial side of the glenoid. As you can see, this is the automatic rasp to go all the way, but you have to be careful that you then need to take more and more from the glenoid bone. Then always I check from posterior to anterior with this gauged probe to make sure that I have a proper bone loss or how many bone loss I have. Then after that, I need to make sure that I take all the capsulolabral to make room for the graft. Then I introduce the needle to make perpendicular to the glenoid, and this is where the posterior portal for the guide, and I need to widen this a little bit to make sure that I have a proper window for this guide. So if you can see this guide, this is a hook guide, which is almost like 8 millimeter from the glenoid surface with 2 slots for cannulated drill bits, one inferior and one superior. Then I have to make sure these drill bits should be 5 millimeters below the glenoid surface. And it's very important that we have picked the proper side where the graft you need to fix on. So you need in the inferior part. So you can see this is the inferior drill and this is the superior drill. Then after that, I retrieve the wire from these cannulated, and I take these wires through the interval itself and make sure that I pass a fiber length to pass the fiber tape, because I need a very strong material to pass these fiber tape. Then I switch my camera all the way to the posterior portal to make sure that I have opened the interval very well to have a good room for delivering the graft. So the one trick that I use, that I make sure that I have proper, that you can see this is my gloves and this is my index finger. So if you introduce your index finger all the way through the interval, that's meaning that you have a proper space for the grafting. Then I'm pulling now from the posterior part with the suture all the way to delivering the graft, as you can see here. One point here that sometimes you can face some problem with the orientation of the graft that could be flipped upside down during delivering that. So how we can overcome this by doing a leading suture in the proximal hole, and you just pull in this leading suture to make sure that you are going in a vertical fashion, not going for the in a horizontal fashion. Then after that, you have to manipulate the graft all the way to make sure that you are setting down the graft in a proper position. And then I'm viewing from the anterior superior part just to make sure that I'm controlling from anterior superior the camera. Then you can see that I'm happy with this. And now I start to do a knot tying from posterior with the tensioner to make sure I'm achieving a proper tension for the graft, as you can see here. So actually, what I did modification in last few cases, that you can see this is a screenshot that the graft, you can see that there is some stress on the graft itself because the tension it's over and could break the graft itself. So what I use a small 2-hole plates with the hook. This is invented by Arthrex. It's one for the Latarjet. So I use it for the graft itself, and I put the plate. Then I need to wrap the fiber tape around this plate to distribute the force through the bone itself. And this is the immediate X-ray post-op for one of my patients using the plate. And after that, this is CT scan, almost like 4 weeks post-op. So you can see how far you can go increasing the width of the glenoid. And if you do this, do you still need a sling effect if you almost increase 18 millimeter of the glenoid surface for any instability case? And this is another CT scan 4 months without plate. How you can see how far you can increase the glenoid surface. So what about range of motion? So in these pictures, you cannot tell which one you operated on. So this is the left side, actually. So you can see that he achieved almost a full range of motion. So what's the advantage of this? This is all arthroscopic technique. You don't need to do any open in the shoulder, any open incision. It's can be used either with the fixation. You can do it with an autograft or allograft. And also it requires a small drill here. So I don't want to drill 4.5 or 3.5, 2.4. It will be more than enough just to pass the fiber tape. Then does not use any metal implants. So easy to revision. You will not worry about that the screws in a bad position or it will hitting the heads. And also it's a reproducible techniques and easy to revision because it's all arthroscopic. It's anatomical reconstruction. You can revise this with allograft or you can revise the allografts with autograft and vice versa. What the disadvantages of this? It's a demanding technique, especially when you are delivering the graft through the interval, and require preparation of the graft. So you're gonna take like 15 minutes just to prepare the graft, the autologous iliac crest graft. Always you have to worry about the graft side morbidities, numbness, pain. Sometimes we put plate just to overcome the hole in the iliac crest, and also possibility of wrong graft position. And this is always one of the complications in any kind of bone block procedure, that the position of the graft. So tips, instead you can do a double posterior approach if you don't want to do a one big posterior approach. Always to make sure that your finger go all the way through the interval easily. So this is you'll have enough room for the graft to deliver on. And use a strong material like a fiber link, tiger link to retrieve the circularized tape, and also use the leading stitch just to make sure that the grafts go in a vertical fashion. And what's the pitfalls? Always you have a problem with the capsulolabral complex. You need to open this. You need to release the whole anterior structure to make sure that you have enough room for the graft. How to overcome the guide position? Always you need to make sure that your pins, it's almost like 5 millimeters below the glenoid surface, not more than 5-6 millimeters. Otherwise the graft will be medialized. And also you don't want to be a superficial, otherwise the graft will be lateralized. Thank you.
Thank you so much, Ziyad, for this very interesting technique and nice presentation. I will move on to our last speaker today, Dr. Ivan Wong from Canada. He will share with us his experience, which is very good experience in arthroscopic allograft of distal tibia for reconstruction of bone loss in recurrent instability. Go ahead, Chief.
Thank you. So hopefully this is working.
It is.
Thank you. Okay, perfect. Thank you very much. This was a wonderful chance to join this fantastic panel. We've had great discussion. I'll try to focus in on using distal tibia. Let me see here, my disclosures. So by the end of this session, we'll go over why recreating anatomy is better, the technique for the arthroscopic anatomic glenoid reconstruction, or AAGR, 5 critical flaws of, I think, what the arthroscopic Latarjet has that prevents its worldwide uptake of this novel technique, how AAGR can help to overcome these flaws, the clinical and radiographic outcomes of AAGR, and how AAGR can help manage difficult revision surgery. So again, I don't need to convince you, bone loss causes higher failure rates, but how much bone loss is too much? The number really has gone down from 25 down to 13.5, and maybe even 10% of bone loss is already something you want to consider doing some kind of bone augmentation with. And that 15% bone loss is really when you lose 3 millimeters of bone, that's already when you're considering having significant bone loss that you want to do something about. So not much bone at all. And how often does this happen? Well, almost 50% of all reported cases have at least 10% of bone loss. So if you haven't seen it that often, it's actually seen you just may not have recognized it. John Dickens in the States has done a military study showing that first-time dislocators have on average a 6 bone loss. But if you get more than one dislocation, you get on average 20% bone loss. So if you don't treat first-time shoulder dislocators and treat recurrent dislocators, more often than not, you're going to have to deal with bone loss problems, thus having the surgeries that we're talking about today. Bone loss can also happen with postage stamps. So really repaired successful Bankart surgeries with multiple suture anchors can give you bone loss as well. This interesting study shows 186 patients which did not have bone loss prior to doing a Bankart repair. And what they found is, as you can see on these examples, is even though they do an excellent Bankart repair, they get bony erosion in these young, healthy people. So bone loss can happen many, many different ways. Obviously, bone loss is a bipolar problem. We're really talking about the glenoid this time, but Hill-Sachs is just as important. And this peripheral tract lesion that Itoy has been talking about is actually super important. In fact, a peripheral tract lesion where it's not engaging, although it's close to, within the last 25%, will actually decrease your outcome score. So patient has some sense of apprehension, even though they don't dislocate, they don't do as well as what they could have. So you really got to pay attention to the peripheral tract lesions. So getting back to glenoid bone loss, there's no question. I think Dr. Lehman has talked very carefully that open Latarjet is the gold standard. We should compare everything to it because it stood the test of time. And that's what you really want for an operation. It can address bone loss. But why do we have these meetings? It's because it's still not perfect. It's not anatomic. So we don't care about everything going arthroscopic, but we care about all our surgeries becoming anatomic because that is what the body is designed to do. It also has a high complication rate. If you don't do that operation very often, you won't get the same results that he may get. And you still get the progression of glenohumeral arthritis, which means more surgeries in future. And just like this picture shows, that's one of the most deadly operations you want to go for someone who's previously failed the Latarjet. All the anatomies changed. So we'll talk about that. Again, we know open Latarjet is definitely more reliable than an arthroscopic Bankart repair, talking about long-term outcomes. So Latarjet trades the decrease in recurrence rate for an increase in complication rate and more difficulties in surgery with future revisions. So that is the crux of this. And this is why we're talking about this problem. Why arthroscopic Latarjet? We had a wonderful presentation by Bishai talking about Laurent's technique, get a better visualization, treat other pathologies, hopefully get better accuracy of the graft, leading to less OA, but you still have to visualize the nerve going through that subscap, and that's the dangerous part. So I've gone to learn the arthroscopic Latarjet, and that's how I started my techniques. But even though we've changed the technique to be able to do it in a lateral diffuse position, which allows more surgeons to be able to do, it still didn't get uptake. I don't remember any surgeon that continues to do this because either that or I wasn't a very good teacher. But they all told me it was a very hard learning curve. It doesn't address the capsule. You're still close to the nerve with the same inherent risk for neurovascular injury. You still have to split the subscap muscle, and failure from an arthroscopic Latarjet still makes revision surgery more difficult. So I think the ideal surgical technique is something that's anatomic, arthroscopic, has a low complication rate, preserves the subscap, addresses the bone, and allows you to do a Bankart repair with no bone loss. So the idea of an anatomic glenoid reconstruction is not new. Matt Provencher produced his first series in 2009 with his first 3 cases. And the most common question is, do you need the sling to maintain stability? This probably is the best paper out there. This is a near award paper from JSES in 2019, which is a level 1 randomized controlled trial study looking at 60 patients with 2-year follow-up, those treated with Latarjet versus those treated with a glenoid bone block, so an iliac crest bone block, no conjoint sling. Essentially, they found at 2 years, there's no difference between the two, radiographically or clinically, no dislocations. So we do not need a sling if you can recreate the glenoid bone. We've published our technique, if you want to go into it, in 2015 of how to do this arthroscopically. In brief, I do it in a lateral diffuse position. Arm is placed in a pneumatic holder. The blue portals are my regular arthroscopic Bankart portals. You already had a wonderful discussion about this, seeing how it's done. But the red portal is the Halifax portal. So an inside-out technique that Bishai Shariff has talked about how to do. So we start off by debriding the glenoid neck. We open the rotator interval. We measured the glenoid size so we know what kind of graft size. And by using some kind of bone block, you can actually size it appropriately. You dissect anterior to subscap between subscap and conjoint. Then you shape the bone graft on the back table. You make it whatever shape you want to be able to recreate that graft and place this on this double barrel cannula. You place it in the Halifax portals, a switching stick that's parallel to glenoid, superior to subscap, and lateral to conjoin. You open up that interval and then you slide the graft through that portal. This is a safe portal. I'll show you how it is afterwards. Then, because we didn't do anything to the subscap, we reduce it back into the right spot, and then we do a regular Bankart repair on top of this. So how does this look? This is a right shoulder. You can see the outside view on the left side of the screen, the inside view on the right. You see the significant amount of bone loss coming in here. And that bone loss is about 10 millimeters of bone. So we start off doing the regular Bankart release. So it's this elevator knife from the anterior inferior portal. Again, you can see from the outside view, the angle of approach you have to do to be able to do this release all the way down. This is the Halifax portal. Switching stick, parallel to the glenoid, there's subscap, superior to subscap, there's conjoin, lateral to conjoin. Now we push down with the arm internal rotated. You can see the angle that we get. We can get to the inferior aspect of the glenoid, just like you would expect, just like you would have shown before. Once we get that portal, we insert the graft through the same place using half pipe cannulas to open that space. And now you can see it inside the shoulder. So I'd argue that this view is better than anything you can see open. It's through that deep dark hole. It's hard to make sure it's parallel. This, I have a switching stick in there to make sure my graft is perfectly parallel to the face of the glenoid. And because we didn't touch the subscap, I can actually reduce the subscap back in the right place. And now because I preserved the glenoid-labral complex in that capsulotomy that you're asking about, so I do a vertical release of that capsule, I can shift it from inferior to superior, repaired on the glenoid, and at time 0, the shoulder is completely stable with that Bankart repair with no bone loss. So, biggest things that people talk about, learning curve. Well, Laurent Lafosse and his team has shown that it needs about 25 cases to show that you can have a decreased surgery time. But the trouble is the complication rate did not decrease. You still got hematomas, nerve palsies, recurrent dislocations, infections, screws being too long, and graft breakage. We've looked at our data and shows that it took us about 9 cases to get to proficiency. We didn't have any of those complications, mainly because of the approach is much easier to do. And 9 cases to get the graft exactly where we want every time. Why is the learning curve easier? Well, you look at the portal placements between the arthroscopic Latarjet on the left versus the anatomic glenoid on the right. We only have 1 extra portal, which is the Halifax portal. And again, I'll look at that again. In fact, it is easy enough that now we do these broadcasts. This is something we just did 2 weeks ago. Surgeons want to see this live because want to see our decision-making going through. We're able to show multiple views, and you can see this is an outside view. We can show the inside views as well as how the graft prepped, right? So we can look at how you mark the graft, how you size it, how you shape it, how you make it fit the exact portion of the shoulder. Now we can go back to an inside-outside view again when people want to see a live broadcast. This is how you insert the graft back into the shoulder to be able to make sure it's exactly in the right spot. And when you see it live, then you can identify all the details that you want to do if you want to do this yourself. In fact, it's been easy enough that we've been able to do virtual cadaver labs. So now this is another surgeon coming from Texas. He wanted to practice this on a cadaver. So we were able to zoom in and I can draw on top of his screen so he can see. So in this multiple view, multiple camera feed, I can take his screen, show him his own screen, draw on it, and tell him exactly how to make the graft, which size is the articular cartilage, which size is the cancellous bone, where to put the little screw hole so it doesn't fade. I can actually superimpose videos in case he doesn't understand, so you can see and be able to do this when you're not even in the same place. And afterwards, again, I'm not in the room with him doing a cadaver lab. He's able to position this graft on his own. I've never met this surgeon, just going through Zoom. This is how easy this technique is to be able to teach someone to do safely. You've seen this video already. This addresses the capsule. The arthroscopic Latarjet end of it is on the left. The coracoid is definitely there to add as bone, but you can see the humeral head's balancing over the coracoid, in fact, going into the muscle belly of the subscap. So the arthroscopic Latarjet really depends on that conjoint sling to keep the shoulder stabilized. The anatomic glenoid's on the right. You saw we were able to recreate the bone, so it's normal glenoid size, and now we get the Bankart repair, and the humeral head is well balanced over the now normal size glenoid with a Bankart repair on top, and that does not make the shoulder too tight. It's also away from the nerve. This is a cadaveric study that we did. If you do a subscap split here, the subscap, the musculocutaneous nerve and the axillary nerve are always within that subscap split. You may choose not to look at it, but it is there. You will move it away with your retractor. Or you can choose to look at it and try to avoid it. But I think the Halifax portal, where we go through the rotator interval by depressing the subscap and staying lateral to conjoint, makes everything safer. In fact, We've actually dissected it out. These are surgeons that come here to learn the procedure. We dissect it out afterwards to be able to show you. When we take down the conjoint, it completely protects this neurovascular bundle, so you'll never get in the way as long as you identify the landmarks to go in. It doesn't damage the subscap. Again, this is the Halifax boral. Switching stick parallel to glenoid, superior to subscap, lateral to conjoint, and you push down with the arm internal rotated, we can get to the inferior most point of that glenoid. You do not have to worry that you can't get inferior enough by doing this. There's a couple of things for the tricks for releases. You get excellent clinical radiographic outcomes. You can see this is a semi-pro hockey player in Canada, 8 months after surgery. You can't see which shoulder he had operated on. He's actually had it operated on 3 times, failed by 2 other excellent surgeons. And we've had no complications in terms of neurovascular injuries, adverse events, readmissions to hospital, bleeding, infection, or implant failure. We've actually compared our data with our original arthroscopic Latarjet, essentially showing that radiographically, they are identical. We get the same union, healing size, and resorption. Everyone thinks that using distal tibial allograft, you get more resorption. You do not. Using coracoid, you get the same resorption. They look identical. The only difference is the step formation. Using distal tibia, we're getting better congruency. The graft is perfectly aligned with the glenoid, probably because we have the cartilage to help us align that graft as opposed to not having it and trying to recess it down about 4 millimeters. We have our early outcome. You can see, you've already seen this slide showing that we have no dislocations, one feeling of subluxation. I think that's where this near track patient is. You've already seen this. We show that we do have resorption. And I think resorption is the wrong word. The bone remodels. When you put allograft or when you put new bone anywhere, the bone has to revascularize. And when revascularization happens, it only heals the part that gets loaded, which is Wolff's Law. And that's what happens. Because the more important thing is the final width. So these are the same patients we talk about. What you find is the glenoid with the graft afterwards, even though they have a high resorption rate, the size of that is normal. It goes back to 30 millimeters, which is what our intent was. We actually made supersized grafts initially, and I think that's what skews our data. When you make a graft too big, it will resorb, it will remodel because it's not loaded anymore. You cannot make a body do things it doesn't want to do. We've also looked at an economic analysis. We compared Bankart repair. So in North America, many surgeons prefer to try a Bankart repair first, and then if it fails, do a bony procedure versus doing the anatomic glenoid right away. And at all time points and all willingness to pay, it is more cost effective to do the arthroscopic anatomic glenoid, even though it's more cost effective because it reduces failure rates. So hopefully we've been able to show you that arthroscopic anatomic glenoid has a faster learning curve like the Bankart repair, are able to repair the capsule, it's safe away from neurovascular structures, doesn't damage the subscap muscle, as well as being anatomic. It does not make future revision surgeries more difficult, and it's cost effective. But what about revising failed Latarjets, that difficult thing? We know that Latarjet changes the neurovascular structures. The musculocutaneous nerve becomes more inferior and anterior to the glenoid rim. The axillary musculocutaneous nerves are tethered in the brachial plexus, and now they overlap, and identification is difficult from this study by Mike Freehill. Dr. Preventure and Romeo looked at this and said the approach to this has to be the same. You still go through the same deltopectoral interval. You still have to figure out if you're doing a subscap split or takedown. You still have to identify the conjoint in a scarred mess, and you must be brave because you will not easily identify the neurovascular structures anymore. So what if you get this patient, 26-year-old male, right shoulder dislocation, first time in a hockey, now occurs randomly on his own, had 2 surgeries already, an open Bankart, then an arthroscopic Bankart, and then, you know, having everything essentially normal except for apprehension and slight weakness in the subscap, with x-rays like this showing that you're having some bone loss anteriorly that you're worried about. CT scan showing the previous anchor holes with some bone loss anteriorly again. And then, you know, we do know he has a failed Bankart, failed arthroscopic Bankart, and with glenoid bone loss. Most people do an open Latarjet. And I agree, that is definitely the gold standard, what we teach. That is what happens. But this person continued to have pain 6 months after surgery. No trauma, no dislocation, just more apprehension, difficult to move, and more weakness in the subscap. More decreased range of motion in his physical exam, but neurovascular status is normal. We get his x-ray 1 year later, and this is what happens. A CT scan, you can see how the graft did not heal, pulled apart in fact, and is failing miserably, the screws coming out. What do you do with this patient? So Latarjet is not the end stage because it makes your life more difficult when it fails, because usually somebody will need surgery at some point in life. These are young patients. So what does it look like? Well, this patient here, we go through. So he's had 3 surgeries already. You can see this is why he's having arthritis. When we look in from the posterior portal. Oh, sorry. I pressed the wrong button. Let's see if we can do that again. So this is a view from the anterior superior portal. And what you can see here is we can see actually through the capsular repair that they had. You can actually see the screws in there. You can see the arthritis that's been happening. Now this is my my anterior inferior portal. I put my cautery in here, try to get at it. And you can see this angle is terrible. I cannot get those screws from the open Latarjet that they did. But if we do a Halifax portal, you can see I can actually remove those screws easily. I can get the graft in the same hole that we just did from the Halifax portal. It actually can get you the same location that you would do from open surgery. That's why I want to show that part. Then because we left all the capsulolabral complex together and we're able to redo the whole graft to make the glenoid the normal size, we can repair the Bankart on top of this to give them a nice stable structure afterwards. So it makes your scary approach to a failed Latarjet much easier and in fact, I think much safer. This is his pre-op x-rays and CT scan above in the first half. You can see the post-op x-rays and CT scans below. So you definitely can get the same benefits of a Latarjet with only the risk profile of an arthroscopic Bankart repair. This again is a faster learning curve. It's similar to Bankart. It allows you to repair the capsule. It's safe. It's away from neurovascular structures. Doesn't damage the subscap, and it's anatomic, which is key. It does not make future revisions more difficult. In fact, it may make it easier to revise a previous Latarjet. Thank you.